So SBIRT is Screening, Brief Intervention, and Referral to Treatment. It's a comprehensive public health approach that creates awareness about the #1 preventable health issue, which is substance abuse.
The target population for SBIRT is the at-risk user, someone who is taking risks with their drug use, but they're not at the point where they're physiologically dependent on the substance.
So SBIRT is an opportunity in the emergency department to let people know some of the dangers behind increased alcohol use, and sometimes head that off before it really becomes a problem.
A lot of patients, when I come in the morning, have been out binge drinking throughout the night and using large quantities of drugs. So as a healthcare provider, I feel it's my job to take the opportunity that I have at the bedside to provide them with the knowledge that might allow them to make better decisions and show them there are interventions and prevention steps.
Having a brief conversation with patients about their substance use, particularly around alcohol, has an effect. Just asking them to quantify how much they're using has an effect.
I remember this gentleman that came in, and I was asking the screening, brief, intervention, referral to treatment questions to him, and I could just see it click when he had to verbalize how many drinks that he has every day. He kind of stopped, and it kind of clicked to him that, yeah, maybe he does have a problem.
When you give them that feedback about what are normative levels, some patients, when you give them the levels, most people don't even know that if you have more than 3 drinks per occasion, every time you drink for women, or more than 4 per occasion for men, then you're basically binge drinking, and pretty soon you develop tolerance. Tolerance leads to more drinking, and that leads to health consequences.
And when you make the connection that they wouldn't have gotten in the fight, they wouldn't have been assaulted, they wouldn't have gotten in the car accident or motorcycle accident if they hadn't been drinking. And once you can make that connection with them, they become incredibly receptive.
We actually had a patient just recently who was in for lung disease, and she had been smoking since she was 15, so over 30 years, 2 to 3 packs a day. And it was very clear very early that her breathing issues were directly related to her smoking. We've talked for a long time about her smoking, about different strategies for quitting, about whether she was ready or not. But it was really that conversation that I think was the biggest benefit she got from the clinic that day.
I don't think of myself as a counselor, but I am a healthcare provider, and I do like my patients to have the best care possible, and I think included in the overall care of the patient is discussion with them about their substance use.
I'm not just here to treat people physically. I'm here to treat them mentally, emotionally, socially. My role encompasses all of those areas. And although SBIRT might not fit into just the medical model, it does fit into the rest of my scope of practice.
Studies have shown that it's effective in almost any healthcare setting. Surgery clinics, primary care clinics, urgent care clinics. There is no wrong setting to have a conversation with a patient about substance use and giving feedback on it and the health consequences of it.
While I am examining the patient, while I am bringing them food afterwards, or even while I'm suturing up their face, you can bring up these topics, and actually by broaching it in those atmospheres, it's not as threatening of a topic to bring up, and the people seem more receptive to talking about it.
I do feel like they listen. I do feel like they are grateful for the feedback, for the help that we as SBIRT health educators provide to them. And this hospital setting provides a real teachable moment for the patients here. But still, if they're not ready, it's not going to happen. So I always say you have to be ready here in order to make a change. And that's with anything in life you want to do, though.
I think in the patients who you do make a difference in, you can see that difference right away at the bedside when you carry out that conversation. You can see the light bulb go off in their head. You can see the switch get flipped. And although you may not see them again and you may not follow up with them again, oftentimes just the sense from talking to them, you know that you've made a change and that you made a difference in these patients.
So once in a while we do get feedback from patients that lets us know that SBIRT is making a difference. I recently received a letter from Jacob. Dear Megan, I'm not sure if you remember me or not. You came to speak to me at Denver Health when I overdosed on heroin. I just wanted you to know that I'm in treatment, alive and well, and grateful I made it there. I suppose I was compelled to write you because even though I was under the influence when I met you, I left the hospital really feeling like I talked to someone who cared. And that was a little reprieve after a profoundly depressing situation. So I just wanted to say thank you. Sincerely, Jacob.
So when there's a patient who is ready to change and wants to quit smoking or drinking or doing drugs, what we can do is we can refer them to treatment. And there's various resources that we have where they go and get counseling and get help, because we do know that that is a huge part of quitting any kind of substance, is that constant support.
Through SBIRT, we're able to connect these dots and really get people to a place where they understand that there is a network out there for them, that there are resources, and that we as healthcare professionals want to help try and make that linkage to care.
The major barriers to implementing SBIRT in a program are really based on probably perceptions by the emergency department providers, the perception that it's going to take time, the perception that it's not going to be helpful, and the perception that our patients may not want to even talk about it.
My initial thought was it was going to be very difficult to implement, especially in a busy emergency department. Since I've been practicing it, I found that it's actually very easy to do.
It's turned out to be very simple to use. It's quick, it's very easy to understand, very easy for us to implement, and overall very effective in the impact it has on our patients.
So you can't force a patient to change, but with SBIRT, what you can do is plant seeds in the patient's mind that really help them reinforce, hey, you know, she's talking to me about this, and maybe when I go home, maybe I'm not ready today to take that step to quit smoking, but maybe I'll think about what she brought to me today.
They may not admit to it, they may deny things when they're in the emergency department, but giving them a few facts, a few pieces of information, even if they don't want to have an actual conversation with you, has at least taken the first step.
As far as what they do with that information, it's their own personal choice. And I have found that I may not know this time what someone's going to do with that information, but I might be planting the seed.
They listen and they do give us the attention for just a few minutes, and sometimes I can see that light go off, even if it's not going to be this week or next week, you know, a couple months or maybe even a year, they're going to want to quit.
When people are hearing that message multiple times from different healthcare professionals, then it does seem to sink into them. That's one of the best things, is that the more we do this, the better off we are in terms of actually espousing prevention and really reversing some of the self-destructive behavior that leads to a lot of unnecessary treatment.
You have this conversation with the patient, especially if you're in a clinic or an emergency department, and you may never see the patient again. So you really don't know what the effects are. You can't appreciate that. That's why the follow-up studies are so important to give back to providers.
We definitely do see results based on the studies that have been done showing that patients will respond to the conversation. I don't know that having the conversation is going to have an impact on the specific patient in front of me, but I do know that those patients who are at risk show significant decreases in their risky behavior after having that conversation. And to me, that kind of evidence is very important in helping me implement the SBIRT into my daily practice.
You hear a lot about statistics, different, you know, how it's impacting long term, how many people, but here in the surgery clinic, it's really about one patient at a time, and really taking that 5-10 minutes with the patient individually and sitting down and saying, hey, I care about what things that you're bringing to me.
Instead of reaching for that drink or reaching for that substance, maybe they'll think twice, and that alone could be a huge impact.
The only bad conversation is not to have the conversation, never to say anything to the patient about their use. That is a missed opportunity.
I do feel like we are making a difference with SBIRT. I do feel like we are reaching out to more patients in a more formal way. I think the patients are benefiting from it.
SBIRT Colorado. One patient, one provider, one conversation at a time.